Hello everyone. Welcome to today's session on management of sleep-related breathing disorders. Yesterday we have seen the presentation by the other doctor on how to diagnose and classify sleep disorders, and today we will discuss the management aspect of the sleep-related breathing disorders. As we have seen, there are several categories of sleep disorders as published by the International Classification of Sleep Disorders by American Academy of Sleep Medicines. The recent version is the ICSD-3-TR, and it has got 7 major group of disorders, of which we are discussing about the sleep-related breathing disorders and its management. You can see that there are several sub-classifications under the sleep-related breathing disorders, which includes obstructive sleep apnea, central sleep apneas, hypoventilation, etc. Like when we are looking at the sleep-related breathing disorders in detail in the same ICSD-3-TR, you can see there are almost 20 plus disorders listed here. We can classify them into major 5 categories or subcategories, let's say. So here the obstructive sleep apnea disorder, the first category, it is caused by the upper airway obstruction, and the classifications include OSA adult and OSA pediatric, and if I'm not mistaken, this is the only sleep disorders mentioned in the ICSD-3 which has got an adult and pediatric subclassification. Then central disorders of central sleep apnea disorders. Here, as the name indicates, here the problem is the unstable ventilation caused by the central areas. There is no airway problem. The issue originates from the central area where the respiratory centers are located. Examples include chain stroke respirations, primary central apneas, medication-induced central apneas like opioid, or even treatment emergent central apnea, where it happens after the use of the CPAP or any other form of treatment to treat obstructive sleep apnea. The third group is the sleep-related hypoventilation disorders. As the name suggests, this involves the ventilation inadequacy. They can result from conditions like obesity, hypoventilation, neuromuscular diseases, where the ventilation becomes inadequate, causing the sleep disturbances and then elevation of the carbon dioxide. The other group is the sleep-related hypoxemia disorders. Here, there is a persistent desaturation in the absence of hypoventilation, or when hypoventilation is suspected, but there is no mechanism to measure the CO2 or its surrogates. Examples include pulmonary fibrosis and COPD, where the main cause is the ventilation perfusion mismatch. The last one is the isolated symptoms and normal variants like snoring and catatonia. So, yesterday we were discussing about the obstructive sleep apnea diagnosis and clinical symptoms, as risk factors, associated comorbidities, economic, financial, or the social impact, etc. So if you are looking at the diagnostic criteria, we have seen it yesterday. A and B plus D or C plus D is required to meet the diagnosis criteria, which is the daytime symptoms and witnessed apnea, gasping, choking, but partner observing the habitual snoring or breathing interruptions, which comes under the 8th category. And with the B, which is the polysomnography or home sleep study, demonstrating 5 or more obstructive respiratory events in an hour during the PSG or TST, HSAT or the home sleep study. And these are caused by, and these are not better explained by any other current sleep disorders or medical disorders or medications or substance abuse. Or C, which is the PSG and HST, showing 15 or more predominantly obstructive respiratory events, with the D, which is the symptoms are not better explained by another current sleep disorder, medical disorder, or medication substance use. For the obstructive sleep apnea, there are several treatment options available. Most common one is the CPAP, which is the most commonly used treatment options for moderate to severe obstructive sleep apnea and in the mild sleep apnea patients with symptoms. Positional therapy, where the supine AHI is at least twice than the non-supine AHI. These options can be tried, and there needs to be special consideration made that the patient doesn't have any orthopedic limitations like shoulder pain or knee or hip joint pain, where the patient is required to sleep on their back. Other than that, this is a good option for those positional sleep apnea patients. Another one is the oral appliances used for the mild to moderate OSA cases, with the mandibular advancement device being one of the most commonest options used under this category. Another option is to weight control, as in the form of an bariatric surgery or lifestyle modification, whatever be it. A weight reduction can be a definite treatment approach for the obstructive sleep apnea. Or it can be in the form of a medication management. New pharmaceutical options recently available, like GLP-1 receptor agonist approved by the FDA, commonly called as a Mounjaro, can be used for the treatment of sleep apnea, which affects by reducing the body weight. We have several surgical options. The traditional one includes UPP, UPPs, palliative angioplasty, adenoid or the tonsils removal, etc. But recently we have this pharyngeal nerve stimulation, hypoglossal nerve stimulation, hypoglossal nerve stimulation in the case of Inspire, or it can be a combination of all these one, as like a CPAP along with the positional therapy, or a CPAP with the mandibular advancement devices. It depends on several factors how we take the different treatment option for the treatment of obstructive sleep apnea. For today's talk, I am tasked with discussion of PAP therapy for the treatment of sleep-related breathing disorders in general, and for obstructive sleep apnea in particular. So we have different types of PAP. Different PAPs are like the CPAP, APAP, and bilevel PAP. We know what is CPAP. The machine delivers a constant pressure throughout the night, and the patient have to use it from the patient will be getting the same pressure irrespective of the sleep stages, sleep positions, etc. But in later there is an upgraded version, which is the auto PAP, where there is an auto adjusting of posterior pressure happens based on the pressure needs of the patient. Especially like a patient may need a high pressure during REM sleep and a supine sleep, and may need a lesser pressure in the NREM and side lying position, and hence this machine automatically adjusts the pressure needs based on the patient's needs. We have a bilevel therapy devices, which is having an IPAP and an EPAP, and bilevel are not commonly used for the obstructive sleep apnea, and it can be considered for those patients where the CPAP or APAP failed, or where the patient is having a pressure intolerance, something like that. So if you're looking at, is there any guidelines for the or a recommendation for the treatment of obstructive sleep apnea, we have a clinical practice guideline published in 2019 by AASM, and it states that there should be an initial discussion with the physician and the patient, and once the preferred choice of treatment as the PAP is decided, look into whether the patient is having any significant comorbidities. If the answer is yes, consider an in-lab titration strategy. And if the answer is no, then consider a home APAP or an in-lab titration study. And the recommendation is that use CPAP or APAP more than or over the BiPAP, so that BiPAP use is very limited for those treatment of obstructive sleep apnea. Additional considerations include educational interventions with routine initiation of PAP therapy and follow-up using telemonitoring or to improve or adherence, etc. So, in summary, the guideline emphasizes once the treatment approach is chosen, the patient education is crucial. Rather than simply telling the patients they have a sleep apnea and need to use the CPAP for life, clinicians should address the patient's questions about what is a sleep apnea, how it affects them, what is CPAP does, how CPAP works to treat the condition, how to troubleshoot the common issues, etc. So from the same guideline, you can see that there are 9 recommendations, of which 4 strong recommendations are there, and then we can see there are a degree of quality of evidences. And you can see the first strong recommendation is that we recommend the clinician to use a CPAP compared to no therapy to treat OSA in adult with excessive sleepiness, and it is the highest level of evidence and is having a benefit over the harm. The second strong recommendation is used to use the CPAP PAP therapy initiated using either APAP or in-lab titration in adult with OSA with no significant comorbidities. And the third strong recommendation is that we recommend the clinician use CPAP or APAP for ongoing treatment of OSA. And the fourth one is the recommend educational interventions be given with the initiation of CPAP therapy, and which signifies the importance of the initial PAP education and the troubleshootings and regular follow-up of these patients. So we know the OSA severity is classified based on the number of the AHI, apnea hypopnea index. Here you can see that 5 to 14 is considered to be mild, 15 to 29 is considered to be moderate, and more than 30 is considered to be severe. Most of the time, sleep apnea with more than 15 needs a treatment, either in the form of a CPAP or devices or a positional therapy. But the approach for the mild cases, the 5 to 15, is more different, is slightly different. The physicians or the clinician may look into other factors like hypoxemic burden or level of severity of the sleepiness or the presence of severe obesity or presence of the comorbidities. For example, a patient with AHI of 10, a physician may choose not to treat it and recommends lifestyle modification, but at the same time, same physician may choose to treat with the CPAP a patient with the AHI of 5 if there is a significant desaturation, a significant level of sleepiness, or significant level of presence of comorbidities. So it depends on not only the AHI number, multiple factors beyond the AHI plays important role in determining whether to initiate the treatment and which treatment approach to use for each individual patients. So once we have decided to go with the PAP therapy, the common question from the patient is how long they need to use the device each night. The standard 4 hours of CPAP is recommended by the CMS for more than 70% of the night for a 30-day period. This is required for the reimbursement purpose and it is not for a clinical purpose. Most of the time it get confused with the clinical purpose, and most of the studies have been done on this 4-hour criteria. The Weaver et al. Published an article in 2007 and demonstrated that the clinical benefit is based on the usage durations. For example, a patient, if you're using more than 4 hours, it improves the subjective level of sleepiness. and an usage of more than 6 hours normalizes the objective level of sleepiness as evidenced by the multiple sleep latency testing, or MSLT, and to improve the functional outcome as measured by the Fosky questionnaire, and usage more than 7.5 hours is required. So it means that there is a dose response relationship between the CPAP usage time and the clinical improvement across the different domains. This one, 7.5 hours, is almost corresponds to the National Sleep Foundation's recommendation of an average adult sleep requirement of 7 to 9 hours. This is the same. This is from the same study showing that different requirement, different level hours of use for different purposes, as explained earlier. Bodhiraja in 2017 published a clinical trial in European Respiratory Journal which shows us the clear dose-response relationship over the use of CPAP in the sleepiness, predictors of sleepiness done after the 6 months of continuous CPAP usage. And we can see that as the number of CPAP hours usage increases, the level of sleepiness decreases dramatically. If we are going with the 4 hours of requirement, we may need to look into further the sleep hypnogram. We know that the first half of the night is mainly N3 sleep or NREM sleep, and the second half of the night is mainly REM sleep. And we know that REM sleep is associated with the severe obstructive sleep apnea. So if you are going with the 4 hours, the first half of the night is covered and the second half of the night is not covered, making the patient vulnerable to have frequent and severe sleep apnea towards the end of their night. And hence, it's important to convey the message that the entire duration of the sleep period is required for an optimal benefit. One important consideration is how we communicate these instructions to the patients. Recently, we had a situation where the patients misinterpreted the instruction. For example, this patient came to us and reported that I'm using only for a short period of time. And why? Because the patient sleep only few hours during the night, and the rest of the time he is sleeping during the daytime, and the doctor told me to use only during the night time, and I am not using it when I am sleeping during the daytime. So give the instructions clear. If you are sleeping for 6 hours a day, use it for 6 hours, and if you are sleeping for 8 hours a day, you use it for 8 hours. And for some reason, for a particular day, you are sleeping only 4 hours per night, 4 hours, and then you use only for 4 hours. So your problem, convey the message that your problem is not day or night, and the problem is sleep, irrespective of the day or the night. Now let's discuss the second group of the disorders, which is the central sleep apnea disorders. Here the primary issue is unstable ventilation due to the problems in the central respiratory control areas. There is no airway obstruction. Central sleep apnea can manifest in several forms like chain stroke respiration, primary central sleep apnea, medication-induced sleep apnea as in the case of opioid misuse, or a treatment-emergent central sleep apnea where you are using it for the treatment of obstructive sleep apnea like a CPAP or any other devices. Now, if you're looking at the central sleep apnea in detail, we can divide the central sleep apnea into those with a high loop gain or those with brainstem dysfunctions. The high loop gain, the example would be the chain stroke breathing pattern, and the mechanism is due to circulatory delay caused by poor cardiac ejection fraction. And what it is resulting is that the brain doesn't receive a real-time monitoring of the CO2 levels and the ventilation status. On the other hand, the brainstem dysfunction, as it is caused by medication induced, like opioid induced central sleep apnea, here, the brain structure, particularly the central chemoreceptors, become desensitized and fails to properly sense the CO2 levels. The characteristics and presentation of the central sleep apnea will differ significantly between these two situations, which impacts both diagnosis and the treatment approaches. Here you can see this is how a classic chain stroke breathing pattern looks like, which is characterized by the crescendo-decrescendo pattern with a central sleep apnea. Such a three characteristic pattern is required, and more than 5 central apnea index is required. We have seen the diagnostic class criteria yesterday from the talk. And today we will be concentrating on the chain stroke breathing pattern treatment. The treatment goal is to reduce the loop gain by therapy of the heart failure. That is the main important. First line of treatment is to stabilize and enhance the cardiac functions. Whether using a CPAP or a ASV or oxygen therapy, if the heart is not stabilized, the intervention will have limited effectiveness, and hence the first line is the treatment and enhancement of cardiac function. The second option for the treatment is to have the CPAP. As per the CANPAP trial, there are two group of peoples were responding to the CPAP. One is the CPAP responders. They get better with the AHI in terms of usage with the CPAP alone, and there are CPAP non-responders. They are not going to get benefited with the CPAP. For those type of patients, the adaptive servo ventilation came into play. However, in 2015, Covey et al. Published a clinical trial which showed increased mortality rate for those patients in central sleep apnea, in systolic heart failure, those using adaptive servo ventilation, and hence AASM published a field safety notice not to use ASV for those patients more than if the ejection fraction is less than 45. Recently, we have seen Bradley et al. Published an ADVANT-HF trial, which is a multi-study report, which is a multinational parallel group open label randomized control trial, which is the phase 3 result is published in Lancet, and which says that there are benefit and there are no all-cause mortality and there is no increased cardiac mortality with the use of ASV, even if the AEF is less than 45, and hence the treatment options can be considered depending on different clinical aspects of the patient. Last option would be to use an oxygen therapy for the treatment of chain stroke respiration, and you can see the treatment the practice parameters for the treatment of central sleep apnea as published by AASM in 2012 mentions that nocturnal oxygen therapy is indicated for the treatment of central sleep apnea syndrome, and you can see the quality of evidences is also here, which gives almost a moderate quality of evidences, and the treatment using the CPAP also have a moderate level of evidences as per the same practice parameters. You can see here the treatment with the oxygen therapy does not confer outcome advantage over the CPAP therapy in the available evidences. The supplemental oxygen can be easily administered and can be given for those individuals with central sleep apnea syndrome related to CHF who are unable to comply with the CPAP therapy. So those patients who cannot be controlled or who cannot tolerate the CPAP, oxygen would be a good alternative options. The same parameter also discuss about the usage of the BiPAP therapy with the spontaneous mode if there is no response to adequate trials of CPAP, adaptive ventilation, and oxygen therapies. So it is the last option. A BiPAP ST will be the last option for the treatment of chain stroke respiration. The second group, the central apnea due to brainstem dysfunction, as in the case of medication use of opioid, you can see that there are short pauses of central apneas interposed by the couple of normal breath, and this continues and the treatment option will be again to reduce or to eliminate the opioid use, and that is the medical management. And then the alternative therapies includes the CPAP, fixed CPAP, adaptive ventilation, bilevel PAP with the backup rate, or oxygen therapies. Another thing to consider here is that when we say CPAP for the chain stroke respiration pattern, or be it with the opioid usage, the central sleep apnea and auto-PAP is not indicated, is not given, because during the central apnea, auto-CPAP will not give any support, and on top of that, during the hyperbreath period, during the chain stroke respiration, it ventilate over and makes the loop gain worse and make the cycle worse, and hence auto CPAP is not a treatment choice for patients with the central sleep apnea and with the chain stroke respiration and the opioid use in general. Now let's discuss the third group of the disorder, sleep-related hypoventilation. So what is the hypoventilation? Hypoventilation is characterized by awake PCO2 more than 45 during with an ABG. To understand the sleep-related hypoventilation properly, we need to consider what happens to the PCO2 during different stages of the sleep. So what do you think what happens for the CO2 while sleeping? During wake, its value is something between 35 to 45 with a mean of 40 mm of Hg. It increases during the NREM sleep. So almost 3 to 7 mm of Hg, it get elevated from the baseline wake baseline value. What happens to the CO2 while in REM sleep? During REM sleep, it get even higher, something between 5 to 9 mm of Hg. So while during, if you recall, the scoring of hypoventilation, there is a criteria saying that there is an increase in 10 mm of Hg increase in arterial PCO2 or the surrogate during sleep. Of course, it has to be more than 10 minutes. But the point I'm trying to make is that an elevation of CO2 from something between 3 to 9 mm of Hg is expected to be normal during sleep, and anything more than 10 is considered to be hypoventilation if it meets the criteria. The transcutaneous and end-tidal carbon dioxide monitoring is required for the hypoventilation to be diagnosed. So we have seen that the CPAP, which is used for the obstructive sleep apnea patient, which will increase the functional residual capacity, and hence it may improve the ventilation and may assist in washout of the carbon dioxide. But in general, a bilevel positive airway pressure is required for the treatment of hypoventilation. As the name says, it is a hypoventilation, and hence we have to ventilate the patient. For the BiPAP, we have two levels of pressure, and higher inspiratory positive airway pressure and a lower expiratory positive airway pressure, and the difference between two is called as the pressure support, or a delta P, or a driving pressure. Higher the pressure support, higher the tidal volume, and higher the ventilation will be. So the treatment option for a hypoventilation disorder is to provide a pressure or a rate support. It can be given by a bilevel PAP, which is in the form of a spontaneous mode, where there is a support for the tidal volume alone, and or using a bilevel ST, where there is a backup rate, and hence there will be a support for the tidal volume and a backup and a rate. Or we can use a volume assured pressure support ventilation. Here we are guaranteeing a fixed tidal volume, and a rate, of course, is given to the patient throughout the night. There are two types of volume assured pressure support ventilation. One is the AVAPS, which is a Philips terminology, and another one is the IVAPS, which is the ResMed terminology. In AVAPS, you are setting a tidal volume and a rate, but on the other hand, in IVAPS, you are setting alveolar tidal volume, which is the tidal volume minus the dead space ventilation. In either cases, what is being guaranteed is that a minute ventilation is guaranteed. So we know the hypoventilations include many disorders like obesity hypoventilation, neuromuscular disorders, or congenital central alveolar hypoventilation, etc. The treatment of obesity hypoventilation is slightly different from the other hypoventilation disorders. ATS, clinical practice guideline published in 2019, gives a clinical guideline how to use the CPAP or NIV for the treatment of urges, and they recommend the use of CPAP over the NIV for the treatment of adult with OHS. And the reasoning behind is that 80 to 90% of the patients with OHS will have obstructive sleep apnea, and of those 70% of patients will be with severe sleep apnea, and hence the recommendation to use a CPAP over NIV for patients having severe OSA, that is evidenced by AHI more than 30 per hour, as a first line rather than NIV. And so the question will be, what is the case? What is the recommendation for those with OHS with less than 30 per hour? And again, the treatment would be is the CPAP, where there is requirement for a frequent checkup of CO2 and oxygenation status. And they recommend that by the continuous use of the CPAP alone will improve the saturation status and will help in the elimination of the CO2. However, it needs to be monitored frequently. So if you're looking at the fourth group of disorders, which is the sleep-related hypoxemia disorders, here the problem is the VQ mismatch, as in the case of pulmonary fibrosis, or it can be due to COPD also, or it can be, there is, as explained earlier, there is a possibility of a hypoventilation, but we cannot diagnose it because of the absence of the CO2 level or its surrogate. The treatment options include the treatment of underlying sleep disorders, as in the case of asthma or a COPD. A medical management is required, and the use of oxygen if there is no sign, if there is no suspicion of hypoventilation. And if there is a suspicion of hypoventilation, to improve the ventilation, we may need to use a PAP, as in the case of CPAP, or most of the time it will be BiPAP, or sometimes it may be a combination of both PAP and oxygenation. The last group of disorders is the sleep-related isolated symptoms and normal variants like snoring and catatonia. Snoring, before labeling it as a habitual snoring, as it is one of the prominent signs of the sleep apnea, If there is a clinical signs and symptoms which is suggestive of obstructive sleep apnea, a sleep study can be done to rule out obstructive sleep apnea. And the case of catathrenia, it is otherwise called as a nocturnal groaning, and it can be treated with CPAP, especially if it is causing any major concerns to the patient, especially the social concerns. And it is most of the time characterized as a central sleep apnea with a long expiratory noise. So the question is, once we have decided to go with a positive airway pressure for the treatment of OSA or for the treatment of sleep-related breathing disorders in general, what is the interface to be used? You can use any form of the interfaces which is shown here, but if you're looking at is there any evidences published in any guidelines, and we can see that the same clinical practice guideline which we discussed earlier having an additional considerations here which mentions that use of nasal interfaces over oral or oronasal interface is suggested, and the use of heated humidification with the PAP therapy to avoid side effects. So it is mentioned, such a recommendation is made based on the studies, and there are several randomized controlled trials and meta-analysis were done to evaluate the effect of different PAP interfaces on apnea hypopnea index, adherence, sleepiness, and quality of life, and the effect on side effects. And they found that nasal mask is way better than oronasal mask. And as you can see a study here, there are multiple studies, and one of the studies published by Landry et al. In Chest 2023 clearly identify that the oronasal mask is having higher collapsibility and hence leading to higher pressure requirement for the treatment of obstructive sleep apnea. There are several reasons which they allocate and hypothesize. Example includes pushing of lower jaw to the back due to the lower strap, which is causing the airway obstruction, worsening the airway obstruction, or the pushing of the tongue with the flow of the air through the mouth, making the airway obstructed. And the opening of the airway keeps the hyoid bone position different, making the retropalatal area reduced space and causing the airway obstructions. So there are several reasoning behind that, and hence the use of nasal mask is preferred over the oronasal mask. However, the mask which is comfortable for the patient needs to be used, but in case of if there is any questions on elevated residual AHI and lack of adherence, or no improvement in the sleepiness, or there is more side effects like mouth leaking, the leak and dryness, or eye irritation, etc., or claustrophobias, etc., we need to change it to nasal mask. The last point to discuss is that during in recent times, mostly used devices are the auto-PAPs. However, we need to make sure that clinicians should know a PAP is not indicated for all the patients, as we were discussing earlier. As per the clinical practice parameters for the use of auto-titrating devices, as published by AASM in 2008, clearly mentions that APAP is contraindicated in congestive heart failure, significant lung disease patients such as COPD, or those patients with the central sleep apnea syndrome, and patients with the nocturnal arterial oxyhemoglobin desaturation due to conditions other than OSA, or those patients who do not snore, either naturally or due to palatal surgery. Most of the time, a pub works on the principles of airway narrowing or vibrations in the airway, But in this type of patient, there is no airway narrowing, and hence it may not be as clinically beneficial as it's supposed to be, and hence care should be taken in the treatment of while treating with the APAP. So, in short, what I have discussed so far is that the obstructive sleep apnea can be treated with the CPAP, APAP mainly, and sometimes a BiPAP may be used if those patients who cannot tolerate CPAP, or there is a pressure intolerance, or if the pressure requirement is higher with these two devices, as the problem here lies in the airway obstruction. In the case of a central apnea sleep disorders, where the unstable ventilation caused by the chemoreceptors or the central areas which control the respiration, and the treatment include the medical management of the pre-existing conditions like heart failure, and the use of ASV and a CPAP, or as a last as an option as an oxygen also can be considered. Here, the APAP is not a treatment of choice, and VAPs should not be used for this type of patient. The third option is the sleep-related breathing, sleep-related hypoventilation disorders. Here, the inadequate ventilation needs to be addressed, and ventilation can be provided by the BiPAP or BiPAP ST and or VAPs. CPAP can be used for the treatment of obesity hypoventilation, and the rest of the conditions needs any of the ventilating devices. Here again, APAP is not indicated and ASV is not indicated. ASV will worsen the hypoventilation and will create more harm than benefit. Most of the time, hypoventilation disorders may need an oxygen along with the PAP. Sleep-related hypoxemia disorder, similar to that of the hypoventilation disorder. Here, the treatment options include the medical treatment of the pre-existing conditions like COPD or asthma or whatever, and then use of oxygen. And most of the time, PAP and oxygen may be required. Isolated symptoms of snoring and catathrenia is debatable, and sometimes CPAP may be used for the treatment of catathrenia. So these are the references I used for this talk, and if there is any question, please let me know. Thank you for listening.